to see you, and thanks for your time on this interview. I appreciate it. I know you're very busy. So I'm over here in Joburg and you are in Lusaka, but I'm still happy that we could have this interview. I would have loved to have it in person. But seeing that we are, miles apart, I think this will do for now. I'm sure in future there'll be other topics that I'll probably have in person with you. So as we get started, maybe let me allow you to introduce yourself to the people who will be watching this and tell us about your background as far as this topic is concerned.
Okay, so my full names are Dr. Ravi Paul. I'm a consultant psychiatrist and head of the Department of Psychiatry at University of Zambia. So I've been in the field of mental health for the last 20 years, and I've been practicing in Zambia for the last 11 years. So my main job involves seeing patients and also training medical doctors to become psychiatrists, and also training mental health to various streams of medicine like physiotherapy, nursing, medical doctors, and the likes. So I've had a very broad experience in the field of depression. Just to let you know that the diagnosis of depression is the most frequently made diagnosis in our outpatient clinics, and almost 1/3 of all patients that come to visit us, they are suffering from some form of depression or the other.
Okay. So it is a growing concern. Sorry, let me let you finish the introduction.
Yeah, so if you see that in the world over, depression will soon take over cardiovascular conditions as a leading cause of morbidity, and that's happening by 2020. So the whole world is reeling under depression, to the extent that in 2017, WHO had depression as their main theme. So the sooner we accept it as a major problem and we become aware of that, then we can seek help early, which is the main thing. An early diagnosis and treatment can prevent major morbidity from happening. And we are trying to make people aware of it. We're trying to popularize mental health, trying to help people understand in what different ways depression can present, so that they're able to embrace their condition and seek early help.
Okay. Well, that's alarming statistics. I was reading that WHO last statistics I saw, they estimated 300 million people worldwide suffering from depression, and it is, as they say, the largest cause of disability worldwide now. So definitely a growing concern, and one reason I am doing this writing and making such interviews and videos to help people understand it better. So over the years, I've also referred people to you who have come to me for help, and so you've helped them a lot. So I know you've dealt with this issue quite a long time. So you've said you get quite a lot of people, and this is your major diagnosis. What's the usual presentation of people with depression that you've seen?
So most of them will come with a very low mood. They'll say that they've been sad for several months or several years at times. Other is like loss of interest in things that they used to enjoy before. Like they don't follow their hobbies anymore. Third could be a social withdrawal. So they're not socializing as much. They're not meeting up with their friends. They're not picking up the best book and reading it. They're not enjoying music anymore. Food seems to be very bland for them. They don't enjoy eating. Sexual interests, they start fading out. They have profound lack of energy. So even to make a minimal effort is something monumental for them. And also they get tired very easily. So with all this, you start seeing that they're showing signs of feeling hopeless. they feel they are helpless, and they're not contributing to the family, they're not contributing to the society and all.
Mm.
That is a typical presentation of a depressive patient.
Okay.
Um, but many others will
Mm-hmm.
not come with a low mood. They'll
Yeah.
come maybe with a poor attention and leading to a poor memory. And that's most of our medical students.
Oh,
They'll
I
come with
see.
a poor memory that
Okay.
I'm not remembering things. Do
Mm-hmm.
I have dementia? And, at early ages, at early stage of their life, they can't be diagnosed with dementia. When you explore more, you find that it's nothing but depression.
Okay.
Okay. Others,
Yeah.
others they come, they're referred from physiotherapy, they're referred
Mm-hmm.
from orthopedics because of chronic backaches, chronic
Mm-hmm.
headaches, or
Mm-hmm.
malaise or fatigue, which is not going away.
Yeah.
And all the tests have been done, and nothing have been proven to be, positive in those. And then a diagnosis of exclusion is tried for, and they send those clients to us to rule out if they are depressed or if they're having any psychological condition.
Oh, I see. That's quite interesting. It's a teaching hospital where you are, so I guess you deal with quite a lot of medical students and so on going through this. So I'm interested in the last part you said, where people present with physical symptoms of depression, physical illness, because that is something I went through for years. I had a lot of sicknesses to the point where I almost got paralyzed in my leg. And I didn't
Mhm.
know that time that I was actually, it's the depression that had driven me to that. So that is quite common then to see such things happening.
It is very common to see somatic presentation of depression.
Yeah.
So body aches and pains and tiredness and fatigue and lack of energy, lack of strength, all that is
Mm-hmm.
very common. Others may come with dyspepsia, flatulence,
Mm-hmm.
intolerance to foods. They can't digest anything. They may
Yeah.
have slow movement of their intestinal tracts leading to constipations.
Mm-hmm. Mm-hmm.
Others may have diarrhea,
Yeah.
losing weight without thinking of dieting or planning a dieting. They
I
keep on
see.
losing weight.
Yeah.
Yeah, so these are common presentations which do
Mm-hmm.
come up, especially in teaching hospitals,
Yeah.
where other clinicians can easily pick up after excluding other diagnoses. They send them over to us.
I guess so. Well, that's interesting. I guess it's something that a lot of people, the public, don't think about, that, some of their conditions that they can't find solutions to could be a mental health issue rather than primarily a physical, a physical or somatic illness. So before we get to the topic for today, we want to focus on is the medication side of depression. But before we get into that, you mentioned that it's a growing problem. WHO has said so, and people are recognizing that we need to bring this to the forefront in terms of talking about it and awareness. Do you have any insight as to what it is that's changing in society that is leading to increase in depression? I mean, what kind of factors are we looking at?
I think it's the westernization or the
Mhm.
modernization of mankind.
Okay.
Um, we are forgetting the human values. We are forgetting that socialization means being person to person in contact with someone and not being
Hmm.
on WhatsApps or Facebooks and knowing other person's whereabouts
I see.
by remotely sitting behind a screen.
Okay.
So as we adapt more and more to gadgets,
Hmm.
we are becoming distant from our actual relationships.
I see.
So other aspect is we are running away from religion and spirituality,
Hmm.
uh, which is the biggest support for someone to come out of a problem. So when someone is in a problem, you find that there is no one to stand by you. And if you had a church mate, if you had a pastor, if you had a spiritual leader, you can go up to, who can infuse a lot of confidence in you, who can give you that um, you know um, a support which no one else can give you.
Okay.
Okay, they don't
Hmm.
demand anything in return. They're
Exactly.
just there to stand by you, and then they show you the correct path.
Hmm.
People are getting involved in a high paced life. I want to buy a better car than my neighbor who
Mm,
has a Benz. I
yeah,
want to have a higher salary. I want to have a bigger house. And in that
exactly.
rat race, we are forgetting that the gist of human life is to be happy.
Mm-hmm.
And that happiness comes from within, not from having things outside, not from materialistic things.
Yeah,
So a materialistic things has an expiry date,
exactly. Yeah.
and your own happiness, which you get from maybe planting a tree, maybe
Mm-hmm.
walking the garden, maybe
Mm-hmm.
holding hands with your loved one, or playing with your children and spending
Yeah.
time with them, is now missing from our daily routines. And that is why we are seeing more and more of depression. Another
Mm-hmm.
aspect is most of the Western world have
Mm-hmm.
seen it all and have done it all. They are the
Mm-hmm.
richest of the rich. They have seen the best kind of atmospheres. They have seen the best kind of gadgets, and they have lived it. They have tasted the best drugs. So for them, nothing remains to be tried and tested, which can give
Okay.
them happiness. So when
Mm.
they come to that strong wall where there is no further path, they feel that they have wasted their life in going
Uh-huh.
around things which never fulfilled them, which never completed them. And when
Okay.
that realization strikes someone, then depression hits very, very hard.
Mm-hmm. Well, I think that's very insightful, and you've touched on things that I personally am also quite passionate about. So yesterday I was having an interview on social media and mental health with uh, Kayumba Tambatamba from the Psychology Association of Zambia, and we discussed some of the dynamics around social media and what it does in terms of mental health and depression. So I'm happy to hear it from you too. And I see in your talk, you talk about things to do with purpose, as you've said, meaning of life and what else is there to life and so on, and our connection with nature. I think those are very important things. And I would have loved to delve into those with you right now, but would probably have to find another time because those are things I'm interested about. But let's go on to now. Uh, so very quickly, let's before we go into treatment. So somebody comes to you or wants to know if they are depressed. They might be having these illnesses or feeling low and so on. How do they know that they are depressed? How do you diagnose somebody with depression?
You see, Doc, the beauty of psychiatry is that we
Mm-hmm.
don't need any blood tests, we don't need any radiological investigations,
Yeah.
uh, or any invasive procedures to know that someone is having a psychiatric ailment or a psychiatric condition. What
Mm-hmm.
all we need is to sit across the patient, to
Mm-hmm.
talk to them, to know about when did the problem start, what are their symptoms like, how long have they been suffering from that condition, and
Mm-hmm.
that is all. We compare their symptoms to the diagnostic guidelines, which are given by WHO and
Mm-hmm.
also by American Psychiatric Association. So
Mm-hmm.
those guidelines are our tools to gauge someone if they fall in a certain diagnostic criteria or not.
Okay.
Okay. So based on that, the number of symptoms that someone has, duration of the symptoms, we will clinch a diagnosis. And
Okay.
then we share it with our client because you have ABCD for this long. Therefore, you fall under the category of major depressive disorder.
Mm-hmm. Mm-hmm. Okay. So it's mainly based on history and knowing the patient, person and discussing with them about their life issues and how they feel and so on. So that's very useful to know. So now somebody has depression. What are the treatment options in terms of drugs? I know there's other ways to handle it. I mean, you've touched on some of them, social contact, talking to other people, nature, and so on. But in terms of drug treatment, what are the options for somebody with depression?
So the first and foremost thing is for someone to accept that they have a condition
Okay.
and that they need help. So
Mm-hmm.
there's a saying that asking for help is a sign of strength and not a sign of weakness.
Okay.
And this is very, very important.
Mm-hmm.
The way we are raised, especially men, we
Mm-hmm.
believe that we can win over everything with our willpower.
Mm-hmm.
Okay, so there are those terms which are used that please stand tall. Okay,
Yeah.
are you not man enough? But
Mm-hmm.
those things are not appropriate to a diagnosis of depression.
Mm-hmm.
Depression is like, if I give you an analogy, it's like a fracture of the brain. It's
Mm-hmm.
like bones which are lying separate. So you can't prey on those two bones and they will join. You can't
Uh-huh.
run a mile and those bones can join. You can't have a wishful thinking. You can't show willpower. You have to
Mm-hmm.
seek treatment, and that treatment is medications. And
Uh-huh.
that is very, very important to start medications as soon as a diagnosis is made.
Okay.
There is a psychopathology behind depression. The
Mm-hmm.
brain cells stop producing serotonin, which is
Mm-hmm.
an essential neurotransmitter to make us feel happy, motivated, to have our normal social and occupational life,
Mm-hmm.
to have normal aspects of pain and other aspects of our somatic presentation. When that serotonin goes missing,
Yeah.
we end up having symptoms of depression. That serotonin cannot be produced by anything else. It
Mm-hmm.
has to be replaced by a medication. And
Okay.
that is how we initiate treatment by giving them serotonin boosting drugs, which are
Mm.
called as antidepressants.
Okay. Okay, that's interesting. And the issue of acceptance, I think, is quite a big issue. As you say, it's not something you can think yourself out of. You need a medication to help you, and there's a lot of stigma in people I've dealt with who want to handle it other ways. They feel that getting on medication is a sign of weakness or admitting that they've failed. So I'm happy you've touched on that. But what's your experience with your patients in terms of getting them to accept and accept medication?
So, what we find, like in my years of experience and the research that we have done in this field, people usually waste 6 months to 1 year before they
Hmm.
see a health professional.
Okay.
So they may go to their church, they may start going through prayers, they may
Mhm.
start changing their lifestyle, they may go to a life coach,
Yeah.
or they may try alternative medicines,
Hmm.
which are found over the counter before
Hmm.
they will see a healthcare professional. And
Yeah.
once they see a healthcare professional, their next question is, how long would I take these medicines? Will it be for rest of my life?
Sure.
And it becomes so difficult to convince them that you have to start the medication first and see
Hmm.
the response. And from there, we'll decide how long will it be continued.
Yeah.
We usually explain that psychiatric conditions, and same is true for depression, they are
Hmm.
like diabetes or hypertension. When
Hmm.
you are diagnosed with diabetes, do you ask your endocrinologist, how long will I need the treatment?
Hmm.
Because there you accept that this is a condition I have to live with for the rest of my life. So the only
Hmm.
way out is medication. When
Okay.
someone diagnoses you with hypertension, you are
Hmm.
scared of having a heart attack. Therefore, the medicines are taken every day without fail. So
I see.
depression, which is the biggest killer in the world now, why do
Hmm.
we keep arguing about why I need to take medicines? Can't I just do without them? Okay,
Hmm.
how long will I take it? What are the
Yeah.
side effects, doctor? Okay, what do you think? Will I become addicted to them? Can I do without them? So
Hmm.
there is a plethora of questions that we have to answer day in and day out.
Okay.
And believe me, patients are very skeptical when they start medications. And
Hmm.
you are bearing the responsibility of putting them on medications. So
Yeah.
for me, as one of the few mental health professionals in Zambia, it's a
Hmm.
huge responsibility. So you will find my telephone lines are always on. My
Okay.
WhatsApp is always working so that
Hmm.
when my client goes through any side effects or he has any queries or any doubts about the medications, they
Yeah.
can clear them with me rather than stopping the medication.
I see. Okay. So you make yourself available in case they have difficulties so they can call rather than stop on their own. But I guess it's still a
Yeah,
challenge. I mean, I suppose a lot of people still decide to stop on their own and so on, right?
that's very true. The
Mm-hmm.
same people who were skeptical in starting medications, when they find
Okay.
relief in 6 weeks to 12 weeks,
I
they
see.
their functionality comes back to near normal. And that's
Mm-hmm.
when they start thinking that doctor is just asking us to come back for reviews because he wants to make money.
Yeah.
Okay, and we can easily stop medications on their own. And
I see.
most of them would experiment that. Okay.
Mm-hmm.
So the treatment of depression with medications involves enzyme induction.
Okay.
That enzyme induction takes 4 to 6 weeks. So therefore,
Mm-hmm.
response to an antidepressant takes 4 to 6 weeks to come.
Okay.
Therefore, when they stop the same medications, it will take 4 to 6 weeks before the response will fade out.
I see.
So when they stop a pill today and they don't take
Mm-hmm.
it tomorrow, they
Mm-hmm.
won't immediately become depressed. It will take 4 to 6 weeks before they'll start feeling the same symptoms that they had before.
I
So this
see.
makes them believe that they have recovered. They didn't take the medicine yesterday and they could sleep. They
Yeah.
didn't take the medicine for a week and still their mood was okay. But as
Yeah.
they go down the line, you find them after the end of 2 months, as they
Mm-hmm.
relapse, they come back to you. And then that's when they admit that they made a
Yeah.
mistake. They didn't ask you before stopping the medications.
I see. Yeah. I guess that's very common. Even some of the people I've referred to you, that's always the biggest challenge is they start feeling better and then they feel, well, I don't need to take this anymore, and so on. And inevitably after a few weeks or a month or two, they get back into the same space again and need medication. So is it your experience then that most people, once they start antidepressants, need them for quite a long time, foreseeable time in their life?
So it depends upon the diagnosis. If
Okay.
it is a first episode of depression, we usually
Mhm.
treat for 6 months. And
I
that's the
see.
minimum period of treatment. And if
Okay.
it's a second episode, we treat it for 2 years.
Ah,
Obviously, the doses won't remain the same. Once they've
yes.
improved, we go on gradually to minimal effective dose. And
Uh-huh.
they carry on with that dose. Now, in order to prevent another episode from coming,
Yeah.
so we call it prophylactic treatment.
Okay.
So if it is a third episode, then we treat for 5 years. And
Ah.
beyond that, it is for rest of their life. If someone
Mm-hmm.
has had several episodes, then they will definitely need medicine for rest of their life.
Oh, I see. Well, I don't think that is a common knowledge for a lot of people out there who might be considering medication. So I'm sure they'll find that guidance useful. At least it helps to know the time periods that you need to commit to it initially, if it's your first, second episode, and so on. Maybe that will help people to commit to it. So you talked about serotonin enhancing drugs. What are the examples of some of those drugs that you
So the
commonly
very
use?
basic one is fluoxetine. That was the first one to be introduced.
Okay.
It is popularly called as Prozac.
Yeah. Okay.
Then after that came sertraline, which is also
Mm-hmm.
called as Zoloft.
Mm-hmm.
And then paroxetine, also called as Paxil.
Yeah.
And there are others like citalopram, escitalopram,
Okay.
venlafaxine,
Uh-huh.
mirtazapine. Yeah, there are several antidepressants.
I
Depends
see.
upon their availability in different parts of the world.
Yeah. So the serotonin in enhancing drugs are the ones you commonly use. So let's focus on those for now. So I mean, what you've talked about the time period one needs to commit, and the fact that you make yourself available in case they're having adverse effects, side effects, and so on. So what are some of those side effects to look out for in somebody that's taking this medication?
So the first thing is that all SSRIs, the
Mhm.
serotonin boosting drugs,
Yeah.
will increase anxiety initially. We call
Okay.
it paradoxical anxiety.
Mm-hmm.
Okay, so for the initial few weeks, we need to add benzodiazepines like anti-anxiety tablets so that the
Okay.
patient is able to adjust to
Mm-hmm.
the increase of anxiety caused by an antidepressant.
Okay.
Once they have
So,
acclimatized to the
mhm.
use, then they will not need benzodiazepines anymore.
Okay.
Then they'll be fine. The same antidepressant will control their anxiety as well as will
Mm-hmm.
control their mood. Usually, the response starts coming in 4 weeks' time. There are some
Mm-hmm.
drugs like escitalopram, which
Mm-hmm.
starts giving the effect in 10 days' time.
Mm-hmm.
There are other medications which may take 4 weeks, others may take 6 weeks. So once we
Okay.
have given a medicine for 6 weeks and
Mm-hmm.
patient doesn't find any relief, that
Mm-hmm.
means that that drug has failed. So we'll try a different drug and see
Okay.
if that was helpful or not.
Aha, I see. Okay, so you do sometimes get cases where one drug fails and then you need to try another drug. Do you try the same class of drug or you try a different class of drug in that case?
Uh, we preferably try a different class of drug,
Okay.
see
Okay.
if that would be more beneficial. It also
Yeah.
depends upon patients presenting complaints. Like
Mm-hmm.
those who present with insomnia,
Yeah.
they are given more sedating medications.
Oh, I
And
see.
those who are
Okay.
presenting with more of sedation and lethargy, they are given more stimulant drugs like
Ah, I see.
clozapine and sertraline or
Yeah. Yeah.
venlafaxine. So sometimes we see if it is more of anxiety than depression, then
Mm-hmm.
paroxetine works better because it's a gold standard for all anxiety disorders.
Oh, I
Uh,
see. Oh.
and if the low mood is the main condition,
Mm-hmm.
then paroxetine and sertraline they work better than others.
Oh, I see. Okay. So it depends on the particular situation of the patient and what their overarching symptoms are, then that you choose the drugs. So in my recollection of these drugs, there's the serotonin, selective serotonin reuptake inhibitors that you've mentioned, the SSRIs. There is is it serotonin and norepinephrine uptake inhibitors and
Yeah, there's
tricyclic
another group.
antidepressants, and I
Yes,
think there's more amine oxidase inhibitors. So
yes.
are you able to give us like a broad overview of those drugs and the circumstances in which you might use those?
So tricyclic antidepressants, they are the
Hmm.
oldest antidepressants known to us.
Okay.
And some of the members of that group are amitriptyline and
Hmm.
imipramine and clomipramine.
Okay.
So tricyclic antidepressants, they block both norepinephrine and serotonin reuptake.
Hmm.
So most of these medications, they have very high level of sedation.
Okay.
They have very strong anticholinergic properties,
Hmm.
and therefore they cause side effects like dryness of mouth, constipation, urinary
Hmm.
hesitancy, sometimes
Okay.
blurring of vision. They also have very strong alpha 1 adrenergic properties, leading to
Hmm.
postural hypertension. Therefore, in the elderly,
Yeah.
we prefer not to give them tricyclic antidepressants.
Okay.
Um, but for those who require sedation, where
Hmm.
insomnia is a major issue, then
Hmm.
tricyclics can work better.
Okay.
Amongst them, especially amitriptyline, can
Hmm.
also be used for tension type headaches. It
Oh, I
is
see.
drug of first choice for neuropathy,
Hmm.
alcoholic neuropathy, diabetic neuropathy.
Okay.
It is also used for several pain syndromes
Hmm.
because they help with the management of pain.
Okay.
But the downside of that is they are very toxic on the heart. And if taken in a higher dose, they can cause cardiac arrhythmias
Hmm.
and can lead to sudden cardiac arrest.
Hmm.
So patients who are suicidal, we do not prescribe them tricyclic antidepressants.
I see. Okay.
And
Okay.
if you don't have a choice,
Hmm.
then we will usually give those medications for only a few days, like
I see.
maximum 1 week prescription,
Yeah.
or entrust the medicines with a friend or a relative who's accompanying the client.
Mm-hmm. Mm-hmm.
They also lower the seizure threshold. So patients who are epileptic may have breakthrough seizures.
Oh.
So that is something which is
Mm-hmm.
alarming about them, and
Okay.
which warrants the lesser use. But
I see.
in some patients who are newly married,
Mm-hmm.
um, sexual functioning is very important. So
Okay.
tricyclic antidepressants do not affect the sexual functioning to that extent as
Mm-hmm.
SSRIs would do.
Okay.
So because of that, they may be drugs of first choice in
Mm-hmm.
newly married couples or sexually active people,
Okay.
um, in which the SSRIs may cause a loss of libido or other sexual dysfunctions.
Okay.
Then SSRIs, they are the drugs of first choice
Mm-hmm.
because of the safety levels. Now
Uh-huh.
they are very safe medications. Even if it is taken in a higher dose, most
Mm-hmm.
SSRIs will not cause any fatal side effect.
Okay. Okay.
Um, as I mentioned earlier, they do increase anxiety when they are started, so we have to add a benzodiazepine
Yeah.
to that. Um, they cause sexual dysfunction in 90% of the population, both male and females that are taking it.
I
And
see.
it's loss of libido, it's erectile dysfunction,
Mm-hmm.
uh, anorgasmia. There is no experience of orgasm when someone is taking it.
Okay.
Um, and and these side effects, they don't go away. The patient does
Mm-hmm.
not develop tolerance to that. So if they continue taking it, then they keep on having this side effect. So
I see.
then we have to plan how to dose them. Sometimes
Mm-hmm.
we ask them to not to take an SSRI until they have had a sexual intercourse that day.
Oh, I see.
Take it last thing, or
Mm-hmm.
we advise them to go on a drug holiday over the weekend if that is when they're planning to meet their partner.
Okay.
Um, or there are some drugs called serotolytic agents, and one of them is cyproheptadine. So they
Mm-hmm.
can take cyproheptadine to counteract the serotonergic activity which is causing the sexual dysfunction.
Okay.
So obviously, with young couples,
Mm-hmm.
sexuality is of big importance,
Mm-hmm.
and that may become a reason for discontinuation of treatment if you
I
do
see.
not manage it properly.
Okay. Oh,
Okay.
that's quite
Other than
interesting.
that,
Mm-hmm.
yeah.
Yes,
Other
please.
than that, it's the GI disturbance. Like most SSRIs cause nausea, gastritis,
Mm-hmm.
and dyspepsia, flatulence. So we may need a proton pump inhibitor for some time when we
Yeah.
start. Yeah.
Oh,
Um, if they're taken in higher doses, they may lead to a condition called serotonin syndrome,
mm-hmm.
wherein a person is extremely agitated and anxious.
Okay.
Um, and that is one of the side effects if people are combining two SSRIs or taking one in a higher dose.
I see. Okay.
So, a newer class of drugs that was introduced was serotonin norepinephrine reuptake inhibitors.
Yeah.
And the molecule in this category is venlafaxine. So,
Mm-hmm.
it prevents reuptake of both serotonin and norepinephrine and
Okay.
was expected to be one of the best antidepressants.
Yes.
We find that it doesn't work better than the SSRIs. So it's
Mm-hmm.
all similar effect. The only good aspect about this is um, that it can be used at very high doses, so up to 300 milligrams per day. It's a
Okay.
stimulant drug. So those people who are feeling very lethargic and fatigued and tired, it may be able to stimulate them a bit
Mm-hmm.
more. Um, and the side effect of this is it increases the blood pressure, it causes hypertension. So people who are
Okay.
already on antihypertensives, they may have to be on the watch because their blood pressures may increase by 5 to 10 millimeters of mercury, and
Oh,
they
that's
may have, yeah. So
mm-hmm.
monoamine oxidase inhibitors, they were introduced many years ago, many decades ago rather, but they
Yeah.
lost their sting because of the side effect, which is called as cheese reaction. So
Okay.
where they cause an adrenaline crisis if
Mm-hmm.
they are taken along with um, any food products which have tyramine in it.
I see.
So
Like,
person
yeah.
can go into hyperadrenergic states. For example, any packed foods, for example,
Mm-hmm.
cheese, processed cheese and stuff. So as people may take accidentally and can go into a life-threatening state. So
Yeah.
these drugs are not used so widely, especially in Zambia. We don't have any of those.
Okay.
But
Because
for academic
that's
interests, we do talk about that.
I see. Because they're pretty hard to monitor. I read they can even cause stroke and so on because of increased blood pressure. So that's very interesting. So I get the idea that the most common drugs used then are the selective serotonin reuptake inhibitor, the SSRIs, and the tricyclic antidepressants.
Yes.
And then you put in other medication to counteract either the side effects initially or whatever other condition the person might be complaining from to manage that. So that's quite interesting. It seems like a very complex process where it needs to be managed by a professional like you. So do you have cases? I mean, I know these are prescription drugs, but I know that in our countries like Zambia, of people self-medicating.
Yes. You see,
Mm-hmm.
the self-medication starts with taking drugs of abuse. So people
Uh-huh.
may resort to drinking alcohol because it takes away their depression for some time when they're drinking. And
Okay.
they end up becoming dependent on alcohol in addition to being depressed. Alcohol is the worst depressant known to us. It depresses the brain further. It
Okay.
has some anti-anxiety effect when the person
Mm-hmm.
takes it and they feel a bit euphoric. But then
Yeah.
after some time, as alcohol is leaving the system, the person feels
Mm-hmm.
more depressed. So most cases of suicide or homicide occur when
Yeah.
someone is under the influence of alcohol.
Okay. Mm-hmm.
So that is one aspect of self-medication.
Mm-hmm.
Other, we are seeing more and more commonly cannabis being used
Mm-hmm.
um, as a way of self-medicating. So cannabis is mainly used for insomnia. So people say they are able to sleep better when they
Okay.
smoke weed.
Mm-hmm.
But they don't know that all the drugs of abuse, they
Mm-hmm.
only induce sleep, but they wake up in the middle of the night and they can't go back to sleep.
I see.
So
It's a
they cause
short-lived
mental
effect.
insomnia. It's a
Mm-hmm.
short-lived effect. And the sleep quality is way reduced and
I
they
see.
feel more tired when they wake up in the morning finally.
Mm-hmm.
It's not a smooth sleep, it's not rejuvenating sleep.
I see. Okay. The quality of the
Then,
sleep is less. Yes.
yeah, then people also go on to get St. John's wort, which is
Mhm.
found over the counter, or
Okay.
sometimes they take valerian extract.
Mm-hmm.
So us as psychiatrists, we are strictly against those medications
Mm-hmm.
because they are serotonin boosters, but they're not selective serotonin boosters.
Okay.
People may buy them in the guise of them being herbs, but they
Mm-hmm.
don't know the side effects which are caused by them are way too many
I see.
than even
Okay.
caused by the SSRIs. Because I
Mm-hmm.
usually give an example. If you have to taste a mango, you don't eat the whole
Yes.
tree. Okay.
That's a good one.
So,
Yeah.
so if you are trying to get an antidepressant effect, why don't
Mm-hmm.
you use an SSRI? Why do you have to use the whole tree, which is a valerian extract or St.
See.
John's wort?
Mm-hmm. Mm-hmm.
So
Okay.
the side effects are way too many to them,
Mm-hmm.
and the therapeutic benefits are very little.
Okay. Compared to the
But
risks, I guess. Yes.
others may would want to go and see a pharmacist and
Mm-hmm.
request him or her to prescribe them medications, and
Yeah.
which is a wrong practice. All
Mm-hmm.
psychiatric drugs are prescription drugs. They
True.
should not be bought online. They shouldn't be bought over the counter from a pharmacist.
Mm-hmm.
They should be properly prescribed by a psychiatrist or a mental health professional
Yeah.
who would advise you and make you aware of how this medicine works. What are the
Mm-hmm.
side effects that you should be on the lookout for? And what should
Mm-hmm.
you do in the event of having a side effect?
I see.
So
Yeah.
that knowledge is not so good with a pharmacist, and that
Mm-hmm.
may lead to serious side effects, okay, or
Uh-huh.
that to dependence on certain drugs,
Yeah.
um, drugs being taken for longer duration than they were intended to,
I see.
or being
Oh,
stopped out of nowhere when no one had advised them to.
to stop. Yeah. Well, that's quite interesting. I guess that is the aspect of self-medication I never thought about, especially alcohol. I think is also a growing problem in
It
our
is,
societies generally, that people are drinking more and more at younger ages and for longer periods. So it could be one of the factors that is contributing, but also a way of coping with depression that people have. But I guess the bottom line advice here is, for medication purposes, seek help from a professional, a psychiatrist or a mental health professional who can give you the right treatment for your particular situation and whatever you're going through. Uh, so that's very good. Is there a role for, you mentioned cannabis? Is there a role for managed use of cannabis in settings where cannabis is legal for medical purposes, or you don't advise it at all?
as for now, we don't
Mm-hmm.
have any research which is done by NHS or
Okay.
NIH
Mm-hmm.
or any big researchers in the health sector.
I
Uh,
see.
FDA hasn't approved it yet.
Mm-hmm.
So, so far, that doesn't happen. We are
Okay.
restricted in the use of cannabis.
I
There
see.
are odd evidences here and there. It is
Mm-hmm.
not a generalized thing that cannabis can help in various psychiatric conditions. There's an
Mm-hmm.
odd case of epilepsy which became better when they put them on cannabis oil. There's an
Yeah.
odd case of bipolar disorder which
Yeah.
benefited from that. But we don't know much about what is the dosage, what should be the ratio between CBD oil and the
Yeah.
THC,
Okay.
and how would you taper it off? What's the maximum dose you can go up to? What side effects we are thinking about?
Yeah.
So all that is still like to be researched, to be documented, and then
Mm-hmm.
to be disseminated to the society. Um, these are overzealous claims for now.
Okay.
People are making big claims, and there's
Yeah.
very little research which is supporting that.
Okay. I guess that's a good point, that there's no body of scientific knowledge that says it works, and how should it work, how much to give, when to give it, when to stop it, and so on. So we're probably quite away from clinical trials and those kinds of things to inform us on those kinds of nuances. So I think that's very helpful. So as we wind up, when somebody is on antidepressants, so you've mentioned the period and what they can be taking and so on. Are there things they should avoid taking when they're, or doing when they're on antidepressants?
So the main thing that they should avoid is that they should not take any of the
Mm.
vices, like any drugs, including alcohol and cannabis, cigarette smoking. So all
Uh-huh.
those things they enhance the metabolism of the drug.
Oh, I see. Okay.
So the medication is washed out way faster,
Mm-hmm. So it's less
and the
effective.
relapse is less effective, and the relapse is just around the corner if they're doing that.
I see. Okay. Okay. Well, that's very useful to
So
know.
that is
Mhm.
one of the most important things. Second, lifestyle change. They
Yes.
should induce sleep hygiene in their lifestyle. They should sleep at a particular time and wake up
Hmm.
at a time. It is very, very important.
Okay.
Third is healthy eating. They should
Hmm.
choose particular foods. Many people, they want to eat their way out of depression.
Yeah, it's very
So
cool.
they have a
Hmm.
type of depression called atypical depression,
Yeah.
where eat more and they put on a lot of weight.
Hmm. Hmm.
So they should be educated upon what is the right food to eat and how much is the right amount to eat.
I guess so. Hmm.
Exercise produces natural happy hormones called endorphins. So
Hmm.
people who combine exercising with medications, they benefit much more and have a far quicker response than those who are more sedentary.
Okay. Okay.
And in the same vein, spirituality, meditation, religious
Mm.
practices, these
Yes.
congregational prayers, they
Hmm.
all add up, all help. Where
To
medicine is a central pillar, these are
yeah.
all the appendages which will support a person to
Hmm.
come out much faster. So all these should be included in their lifestyle
I
so
guess.
that they're able to improve in a much better way.
Hmm. Well, I like that because as part of my series, what I'm emphasizing is lifestyle changes in order to cope or manage your depression. That it's not just about drugs or medication or going to psychotherapy and so on. You need to look at your whole lifestyle and see what could be contributing and what can help you manage. So I'm happy you've brought those aspects up, and those are very useful tips for people whether depressed or not. Actually, that these are the kind of things you should be
Yeah,
doing in life anyway to live a healthy life
true.
mentally. Exactly. So Dr. Paul, I know it's your lunchtime and I really appreciate your time. Any last words as we close this interview?
Yeah, I think I didn't touch on the psychotherapy aspect.
Oh, please
Uh,
do.
yeah, so counseling and psychotherapy
Hmm.
is an essential aspect of management of any psychiatric condition and especially depression. So,
Hmm.
a therapist is someone who's a neutral person who does not judge you, who
Hmm.
listens patiently to you, empathizes with your condition, and tries to help you think correct, think positive,
Hmm.
think what is realistic rather than making assumptions and generalizations of minimal situations which can be handled very easily.
I see. Yeah.
So, as we start with medications and patient starts feeling better, they
Hmm.
should include therapy as a regular aspect of their treatment.
I see.
So, after some months of regular treatment, medications can even be stopped and they
Hmm.
can just carry on with therapy for 6 months to 1 year.
I see. Okay. So that's a period
And
you
especially
recommend is 6 months to a year generally.
1 year.
Okay.
Yeah.
Okay.
Especially cognitive behavioral therapy is very effective. It is as
Mhm.
effective as the medications are.
Oh, really? Okay. Okay. So
If
are
done,
these normally combined, or you combine medication and the therapy, or sometimes it's therapy alone, depending on the situation?
ideally we should combine, but
Okay.
again, it's the patient's choice. Many of
Mm-hmm.
them would want not to take medication, so at least therapy will still help them.
Yeah.
And medications alone will help them, but a combination works the best.
Works best. Okay. Well, that's good advice. It's a big
And
topic and something we could. Yes, go on, please.
so my last words would be depression, like any other medical or surgical or mental health condition,
Mm-hmm.
can be treated very, very easily. The onus lies on early diagnosis. How aware are we about our condition? How
Yeah.
early do we seek help? If we sought help early, it may not ever come back in our life again.
True.
And if we keep on delaying, then it may become a chronic health condition.
Mm-hmm.
So, I give another simple example which is easy to understand.
Yes.
Depression is like a balloon which is inflating from the stressful situations we are facing in our life.
Okay.
As the stress increases, the balloon keeps on inflating more and more. And those are our coping skills. We keep on coping until a stage comes when that balloon will burst. And when
Exactly.
it
Yeah.
bursts, that's a permanent condition of the mind. Now you
Mm-hmm.
can't, at that stage, it can only be treated with regular medications, psychotherapy, and counseling. It cannot be cured.
I
So
see.
we have to work much before we reach that stage. That is why
Yeah.
early diagnosis and treatment is the rule, and we should adopt that.
Okay. Well, I think
Thank
that's
you.
wonderful advice. I'm always saddened to hear stories like I did last week of a young man in his 20s in Osaka who committed suicide. And people came up later and said he's been depressed for years. And I was like, well, why? He could have sought help easily, and it need not have come to that. So I'm always
Yes.
saddened by such cases, and it's very preventable, as you're saying, if you seek the help, or if people around you recognize it and say, push you to go and get the help you need. I think it's very avoidable. So I think we need to work hard to change that situation and make sure people know where to get help and can come to places like your place and get the necessary help they need. Dr. Paul, you have wonderful insight. You touched on so many topics that I would like to go into in details. So I'll probably be calling on you again for another interview on particular topics like the therapy and so on, that we can talk about in more detail. But for today, I really appreciate your time and this insight you've given us. Thank you so much.
Thanks. Pleasure is all mine. Thanks so
Okay.
much.